The last part of this segment of the cardiac lecture will be nursing situations for clients with arterial disorders. And arterial disease can affect any artery of the body and can manifest itself as either acute or chronic conditions. What happens is there is a disruption of the arterial blood flow that results from a narrowing or complete obstruction of the vessel, and this can be from a variety of causes. Unfortunately, this disruption of blood flow limits the availability of oxygen and nutrients to the tissues. So the main goal for our clients that have arterial problems is to increase tissue perfusion. This slide lists causes of decreased arterial blood flow. It can be anything from atherosclerosis to a spasm in the artery, to the patient having an embolus or thrombus formation, to increased blood viscosity, trauma, or it could be from a patient that's had a fracture, for example, or some type of an injury that's led to compartment syndrome. In all of these cases, what happens is the tissue needs more oxygen than the blood vessels can supply, and so it leads to ischemia, and necrosis can be the end result if that's not resolved. Assessments of decreased arterial blood flow include the following things. Patients may develop what's called intermittent claudication, and this is where there's actually pain for patients. It's a primary symptoms. They describe it as an aching, cramping sensation when the patient is exercising or walking. And this is just because there's an occlusion of blood flow, not enough blood is getting to the legs. And so that patient's legs, the muscles and tendons and different things down there are not getting enough oxygenation, and that's what causes this crampy, aching type of pain. Rest pain patients may also say happens especially when the legs are elevated. Remember, if the patient has an arterial problem, elevating the legs is actually going to make the problem worse. This is quite different from our patients that have a venous circulation problem, where you want to increase the legs and elevate the legs in order to decrease edema and to help blood flow. With patients with arterial problems, if you elevate the patient's legs, you're actually making the problem worse instead of better. Patients may also have color, warmth, movement difficulties if they have arterial occlusions and arterial problems. So you may see dependent rubor, you may see pallor with elevation, those types of things. The patients may develop poor capillary refill. You may also see pedal pulses that are poor and hard to actually palpate. So that patient you may only be able to find pulses with a Doppler only. You may not be able to palpate them if they have a lot of arterial occlusion. And because of the poor oxygenation to the tissues, you'll start to see changes within the skin integrity, such as shiny, thin, hairless skin, thickened toenails, ulcers, and the patient may actually develop gangrene, infection, and sepsis, which could lead to amputation. So the symptoms that we see with an acute occlusion are what we call the 6 Ps, and the patients will actually develop these, and they include pain, which will be severe and constant. The patient will have pulselessness, maybe diminished or absent pulses, pedal pulses, posterior tibs, that type of thing. You may see that the extremity is extremely pale. The patient may have paralysis, where mobility of the part is limited, and the patient may also develop paresthesias, where there's numbness and tingling of the extremities, and the patient may have poikilothermia, which is coolness of the extremities. So these would be known as your 6 Ps. This picture depicts the clot thrombus formation that can be in a patient that has an arterial occlusion that could lead to the 6 Ps types of symptoms we discussed on the earlier slide. Sorry about the typo on the spelling on the header there, but this is actually demonstrating arterial foot ulcers. So about 20% of all leg ulcers are going to be from arterial insufficiency. And remember, on our last lecture, we talked about probably, I believe it was 75% were from venous problems. So this is an example of a patient that's had an arterial insufficiency problem leading to gangrene and then ulcers. Nursing care for patients with acute arterial occlusion, the main goal is to improve tissue perfusion. So to focus assessments on perfusion, keep that patient on bed rest, The extremity needs to be flat or slightly dependent position to increase blood flow to that extremity. That patient will more than likely be on anticoagulants and thrombolytics, so make sure that the labs are drawn on appropriate manner on those particular medications and follow-up is done on the results. Patients may need surgical repair. If you think of the gangrenous ulcer that was on the slide a couple of slides ago, that patient may need amputations, things like that, and try to keep the skin in the best type of condition that it can possibly be in. Please refer to your readings in your book for further information in this area. Arterial disease is diagnosed with Doppler ultrasound studies, segmental pressure readings, CTs and MRIs, angiography, stress testing, or transcutaneous oximetry are all different methods to diagnose it. So segmental pressure measurements actually looks at comparisons between the upper and lower extremity blood pressures. The measurements should be the same. Your blood pressure in your arm should be very similar to your blood pressure in your leg. If the blood pressure is lower in the legs, the client, it may be indicative that they have an arterial type of a problem. And that's what this picture is actually demonstrating over to the right. This is called an ankle brachial index, and it measures the difference in blood pressure between the upper and lower extremities. And then it looks at this, divides them out. It takes the systolic blood pressure divided by diastolic blood pressure and looks to see what those numbers actually are and looks for if there's stenosis present in those types of things. So typically patients with arterial insufficiency will have an ABI of about 0.5 to 0.95. And clients that have ischemic rest pain might have an ABI of 0.05 or less. And patients with severe tissue damage and ischemia may have ABIs as low as 0.25. So once again, it's the ankle systolic blood pressure divided by the arm systolic blood pressure. Patients with chronic arterial problems, you will typically see intermittent claudication symptoms, rest pain, the pallor, skin changes, hair loss, and changes in the quality of the pulses that are in the legs and the feet, and those types of things. Nursing care for those patients with chronic arterial insufficiency include those listed on this slide: to improve tissue perfusion, to have the patients on appropriate medications such as vasodilators, anticoagulants, antiplatelet inhibitors, and hypolipemics, which help to bring down cholesterol and lipids and all those types of things. And these patients may also need surgery for their particular problem. Examples of antiplatelet aggregation inhibitors would be Plavix, aspirin, and these reduce the risk of arterial thrombosis. And you can find more information in your book on those particular medications. Patients with chronic problems may also be candidates for surgical management to bypass where the stenosis is in the actual vessel itself. And this almost reminds you similar to cardiac angioplasty, except it would be in a vessel that would be typically in the lower extremities. So they may do bypass grafting, they may do angioplasty down in that area. Endarterectomy is actually where they remove the clot from the actual vessel wall, and the patient may require a fem bypass or a fem pot bypass if they need to do some sort of grafting to bypass the vessel. If it's for some reason, if there's a narrowing or stenosis to the point where they cannot repair the area, they may just bypass that area. Unfortunately, about 30% of these arteries, even with the stent placement, will reocclude within about 6 months. So generally they'll stay patent for an average of 1 to 5 years. It's very dependent on that particular patient's body reaction to the stent and how that patient tolerates the procedure and all those types of things. The most common complication for our patients that have arterial disorders is that the patient will require an amputation if the tissue becomes necrotic. This may be indicated if that patient has severe arterial occlusive disease or the patient has developed gangrene, and the level of the amputation is going to be determined by the extent of the injury or the extent of the necrotic tissue that the patient has. So probably about 85% of all surgical amputations are going to be due to severe peripheral vasculatory circulatory impairment. So some pages are listed there on your speaker notes that deal with further information on types of amputations and interventions for patients that have had amputations. Nursing care for the client with peripheral vascular surgery would be to include supportive measures to help with circulation and perfusion, to prevent respiratory complications, to support fluid balance, promote wound healing, and patient family teaching. So fluid balance is very important, so to make sure that these patients have accurate I's and O's, daily weights, monitoring lab values such as BUN and creatinine and electrolytes, all of those types of things. And we've already talked about circulatory assessments on clients with issues before, so you can read through your speaker notes for further information on that. Other threats to circulation include aneurysms. These can also cause arterial occlusions. This is where there is a development of a weakness or outpouching of an arterial wall. The danger is that these outpouching areas can actually make the vessel wall so weak that it can actually rupture. And unfortunately, this can happen quickly and without much warning, and that will be obviously rapidly fatal. A lot of times this outpouching of the artery wall will be about 1.5 times the normal size and will continue to grow and enlarge unless there is treatment for it. Unfortunately, about 1/3 of all patients will die if the aneurysm does indeed rupture. And the risk of rupture obviously increases as the size of the aneurysm increases. So some statistics I was able to find said that 20 to 40% of aneurysms that are greater than about 5 centimeters in diameter will rupture. And after rupture, about 50% of patients will die even if surgery, emergency surgery has been performed. There are many different types of aneurysms. Don't get real hung up on this slide and memorize each of the different ones. Each of the different types of aneurysms has a very similar outcome, and that's what I would like you to focus on, is just what can be the signs and symptoms, what would be the interventions for patients that had an aneurysm, no matter what the type of aneurysm. A dissecting aneurysm you may have heard about before. This is the type that John Ritter had, that he actually died from. He played in several sitcoms and things like that on TV. That's where you actually have a tear in the intima of the aorta, which can lead to hemorrhage because it actually splits the vessel wall. Some common risk factors for the development of aneurysms include atherosclerosis, hypertension, advanced age. Men are more at risk than women, so gender is a factor. Patients that have had trauma to the vessel walls, and it could be something as simple as cigarette smoking, hypertension, diabetes, peripheral arterial disease, those types of things. Congenital abnormalities, and patients that have had certain infections such as syphilis or connective tissue disorders, and a family history of aneurysms also puts patients at a higher risk for developing them. On assessment, there may sometimes be a palpable mass, especially if the patient has an abdominal aortic aneurysm, and if it's a particularly large one. The patient may also have a systolic bruit that's heard upon auscultation. The patient may develop pain in the epigastric area and nausea, or may have abdominal or low back pain, and the patient may have symptoms of intermittent claudication, and this is because the blood flow is being impeded to the lower extremities, and due to this the pedal pulses may be diminished or absent. So once that diagnosis is established, the primary goal is to prevent rupture of the aneurysm and to try and get that aneurysm from not causing that patient further problems. So diagnosis of the aneurysms is going to be done through chest x-ray, ultrasounds. Remember TEE when we talked about that in the cardiac lecture, the transesophageal endoscopy. Patients will also maybe need a CT with contrast or MRI, and the patient may require angiography to look at the size and location of the actual aneurysm. Excuse me, aneurysms between 4 and 6 centimeters will be monitored by ultrasound about every 6 months, and they tend to grow at about a half a centimeter per year. So once they get bigger than 5 to 6 centimeters, they're going to need elective surgery for repair. Medically, if they're a small aneurysm that's just being monitored every few months and the patient is has one that the physician feels can be just medically managed, the patient may be put on beta blockers, antihypertensives, calcium channel blockers, anticoagulants, and those types of things. Vasodilators tend to worsen the dissection if that's the issue, so that might not be a good drug of choice for them. So please see your textbook for further explanations in this area. For that patient that does qualify for elective surgical repair for an aneurysm, while that patient is awaiting surgery, it's important to have abdominal pain assessed, bowel sounds, peripheral circulation, vital signs, urine output, chest pain, and level of consciousness. These will be your first signs that you'll look for if that patient starts to have a leaking from the aneurysm. Those types of things. Obviously, if that aneurysm blows, that patient's going to get shocky very, very quickly, and you'll start to see changes in all of the above symptoms that are listed up there. This particular slide shows surgical management of a patient that's undergoing aneurysm repair, and typically what's done is there's a graft that's actually replaces the area where the vessel wall has become very weak and that type of a thing. There's actually a less invasive type of procedure that can be done also, and it just depends on if that particular patient is a candidate or not. In nursing 123, all of you rotate to surgery to see a particular operation and hang in the OR for a day. When I was a nursing student, this was actually the first surgery that I saw. So it was a abdominal aortic aneurysm repair. So it was very interesting to watch, and certainly that was the morning surgery, and then the afternoon surgery that I actually was in on was an appendectomy, and that looked pretty boring compared to seeing an open abdominal aneurysm with the rib spreaders and having the patient's whole chest cavity open and everything like that for the morning surgery. It was interesting to see. This particular slide looks at surgical management. And this would be an open surgical procedure where they're actually putting the graft in to replace the area where the aneurysm was and those types of things. So they excise the aneurysm and then replace it with a synthetic graft. An endograft, this is actually not a picture of an endograft, but that's, you can read about that in your textbook. It's kind of in the investigational stages, but that's where metal stents would be placed in the aneurysm site via fluoroscopy and then covered with a polyester synthetic type of a fabric. And typically it has less complications and a shorter hospital stay. But that would be the surgeon's call as far as which type of procedure that patient would benefit from the most. Post-op calls for nursing. Obviously, if you think of a patient that had an aneurysm repair in the aortic area, and the patient had it done in the traditional method, that patient is going to have a huge incision. It's going to start in their chest and go all the way to the bottom of their abdominal area. So post-op pain is going to be a big issue with these patients. Altered tissue perfusion is going to be an issue, as is there's a risk for infection, ineffective breathing. They do come back from surgery on a ventilator, and the goal is to get them off of the ventilator very quickly so that they can start getting up and moving around. So physical mobility, constipation, and injury are also issues for these clients. So there's a great care plan in your textbook. Please see the pages on your speaker notes to take a look at that. We talked a little bit earlier that not all aneurysms need surgery. Some are just monitored if they're very small aneurysms. So make sure that that patient is following up on their routine ultrasounds if it's a small aneurysm, under 4 centimeters or so, and make sure that that patient is monitoring their blood pressure and going in for routine checkups to do that and taking their medications as prescribed. This is a NCLEX question that looks at an echocardiogram was indicated for a large thrombus in the left atrium of a patient that came in for heart failure. During the night, the patient complained of severe sudden onset of left foot pain, and you note that there's no pulse palpable in the left foot and that the foot looks cold and pale. So what action should the nurse take next? As you can see, you can look through the speaker notes to look for the correct answer, but it would be very important that you do some follow-up action, obviously, and quickly, so that that patient doesn't end up with a necrotic extremity and that type of a thing. This is just another NCLEX question that you can feel free to read through and look at the speaker notes for the correct answer. Your ATI book has some great NCLEX style questions, and hopefully all of you have bought an NCLEX book at this point and are reviewing NCLEX questions along with your topics so that you can get some further experience on it. And you're probably sitting at a good point now. Also, you have most of the cardiac content except for the EKG interpretation, so you can take also the ATI cardiovascular focus test, and that will give you some more NCLEX type questions also.